Hello everybody, I'm Karim Fizazi, medical oncologist from Gustave Roussy in France. I'm here in Munich for the ESMO meeting, and actually it's the last day of the Congress. It's been really great for GU malignancies and specifically for prostate cancer with lots of great news, new information. And we're going to try to summarize this data for you today at this e-cancer discussion. So let me first ask all the faculties to introduce themselves so that I can just rest and hear from them. Please.
I'm Matthew Smith, medical oncologist from Massachusetts General Hospital Cancer Center in Boston.
Nick James, I'm an oncologist from Birmingham in the UK.
I'm Mark Beresford, an oncologist from Bath in the UK.
And I am Álvaro Pinto, and medical oncologist from the University Hospital La Paz in Madrid, Spain.
All right. So I guess we've heard at this meeting lots of important news of prostate cancer patients, and actually quite across the course of the disease. Let me perhaps start with a quite specific and actually debated space, which is that of the CRPC M0 space. We've heard earlier this year the new data from the Spartan and the Prosper trial at ASCO GU. And now that we have more follow-up, more time to think about it, what is basically your take on from this data? Can you start?
Yeah, so it's an interesting group of patients, as you say, because I think our impression was it was quite a sizable number of patients who were established on androgen deprivation therapy, and their PSAs were rising, and we scanned and couldn't find any metastases. And these two trials, Prosper and Spartan, looked at two different agents, enzalutamide and apalutamide, in patients in that position. And they had a PSA doubling time in both studies of less than 10 months. In the Prosper trial, the PSA had to be above a level of 2 before patients were entered. And there are other studies going on as well, as Aramis trial with other agents, which is similar. But we saw some new data presented looking at the risk groups within those trials at this meeting. And broadly speaking, both drugs improve the time to developing metastases from around a year to a year and a half as the baseline without the agents in both studies to around 3 years, 36 months and 40 months, respectively for Prosper and Spartan. So big improvements in time to developing metastases. Mm-hmm. But obviously at the cost of having relatively expensive agents that do come with some side effects and some impact on quality of life for long periods of time. It's interesting the status of being non-metastatic. I think the harder you look, the more likely you are to find metastases, and we now have new scanning techniques, PSMA scans, choline PET, which may be picking up metastases that we weren't seeing in these trials with the kind of standard imaging perhaps that was done as part of the inclusion criteria in the trial. And that's certainly been my experience in clinical practice, that sometimes we think people might be appropriate for the studies, look harder and you find something that's maybe equivocal or you're not sure and you speak to the radiologist and it could be an early metastasis. So the group perhaps isn't quite so big as we first thought. Mm-hmm. I think we need a little bit more time to pull out real survival benefits from these trials.
Thank you. Nick, do you share this analysis or different thoughts?
I mean, obviously that's a very nice and thorough summary of the data. I have to say in my practice, this group has pretty much disappeared. Mm-hmm. Because on the one hand, you've got PET scanning picking people up who you wouldn't have called metastatic before. We now know where the Mets are. Because of the growing use of stereotactic radiotherapy, that opens up salvage options that are not drug-based. And then at the other end, I have to say we've got more and more relaxed about not putting people on ADT just because their PSA is going up. And there's actually very old data, the pound data shows that you can identify patients who are at very low risk of death and therefore are at guaranteed risk of harm if you put them on ADT and low risk of death from their cancer. So I think it might be the population is disappearing from each end.
Right. Okay.
I'm not sure that the population is disappearing, mm-hmm. but because these weren't all patients with non-metastatic CRPC, they're the upper half of risk. And there certainly are patients,
Sure.
if you look at the entire population, if you look back, there are patients you might wonder whether they ever should have been put on ADT, particularly the slow risers. But the other thing I'd say is, if you separate just the drug or all of that and just say, what's the evidence? One of the really important things, and you pointed out this novel category of disease, which is, novel imaging, PSMA PET positive, conventional imaging negative. There were exactly no patients like that in the pivotal trials that led to approval of all the other agents for mCRPC. So it's really quite an extrapolation to say that, well, if you can find it on PSMA PET, I now would treat them as though they had metastatic disease by conventional imaging. So in many ways, I think one of the more important parts of PROSPER and SPARTAN is we now have the evidence, right? So these are those patients. And more data will emerge about that from our individual clinical experiences, that if you image folks like that, particularly the fast PSA risers, you're going to find a lot of metastatic disease. And we're going to see more data coming out about that from large experiences to support that. So I think in a lot of ways, PROSPER and SPARTAN are going to help us optimally manage patients who fall into this novel category.
I guess my concern, Matt, is that obviously the data are completely consistent with STAMPEDE, ABI, and LATITUDE as well, which is that early use of effective therapies is better than late use in terms of disease-related things. But obviously the data you presented from the ERA 223 trial showed quite high, for example, fracture rates with ABI in quite a late setting, and that was one of the features of SPARTAN and PROSPER as well, fractures and falls and things like that. So I think there is a balance. If you have very long durations, these very active androgen depleting / blocking agents, is for sure we're having impact on prostate cancer related effects, but we may well be having impact we don't want on other things.
Yeah, so that part of the equation of sort of individualizing management is age old, right? I mean, we're going to be making decisions considering benefits and harms, and I think you're right to point out one of the themes that emerged from this meeting was really that fractures in particular are important, and it's not just in SPARTAN and PROSPER, but if you look back at the mCRPC studies of ABI and ENZA, there's excess fractures there too. So one of the consistent things too is that there's really underutilization of osteoporosis prevention or fracture prevention strategies. So many of the patients entering these trials were probably not well managed. For example, in terms of fracture prevention, only about 10% of the patients in SPARTAN came in on a bone sparing agent, despite the fact that they're in their mid-70s and had been on long-term ADT.
So actually it's fun, well, not necessarily fun, but it's interesting to see that we're learning things in parallel to our trials. We're aiming to something with a radiotherapy combo or early use of X agent, CRPCM0 trial, and we're learning that actually bone targeting agents should probably be used much more earlier and more frequently than what we typically do. That's really interesting. So we're still learning. Let me move to a discussion about metastatic disease. That's really a field where in the last 5 years we saw a tremendous amount of good news, I think, for the patients from the docetaxel trials, abiraterone trials, and yesterday at the ESMO Congress, STAMPEDE reported 2 abstracts at the presidential session, which is quite, exceptional. Really, congratulations, fantastic achievement. So, can you just briefly summarize what was presented?
So, thank you. So the first one was the abiraterone data, and as of course you're extremely well aware, the LATITUDE trial was high-risk patients only, and that changed the license and the guidelines for high-risk patients, but didn't include low-risk patients. Now, STAMPEDE included the whole spectrum of metastatic patients, but we didn't categorize the disease by that classification. So the first abstract that we presented was our data reanalyzed according to the LATITUDE criteria, and I guess it wasn't a huge surprise to see that the effect was broadly very similar in the 2 groups. So although it's not within the license strictly, the license, it will be interpreted, we think, quite liberally once this drug is off patent, which it is in some places and will be pretty much everywhere. So I think it's important because it extends the use into both ends of the spectrum. And there has been controversy about whether the docetaxel benefits are equally distributed across high and low volume. So we did think it was important to show whether it was or was not the case with abiraterone.
Before we move to the second abstract,
Yes.
let's maybe comment on that one.
Yeah.
Álvaro, what do you think about this new data?
I think it's fascinating, really. I mean, we're moving to a point now where abiraterone seems to be the best drug for upfront metastatic disease. My concern, of course, a little bit, as we were talking before, is that there's a whole cohort of patients for whom that might be suitable, and we're going to be looking to have these patients on treatment for a long time. So there's clear impact on capacity, on resource, and issues like that. But I think these are data that we can't really ignore, given the huge benefits that are seen for the patients.
Okay.
Yeah, I fully agree. I mean, you have the evidence, you have the data. When you didn't have them, it was more speculating about why not low-risk patients were not going to benefit. But I mean, there you have it, and that links with the next part of the STAMPEDE, the second one. Maybe you even could think about giving everything, even in low risk, because that's the one that get the benefit, ADT, radiation, and DABI. So I think that, of course, this won't be from 0 to 100%. We will still have to individualize to decide which patients may be the ones that benefit most from that strategy, but now you have data. I think it's the most important thing.
I mean, what about the potential approval or reimbursement and access in other countries? What do you think for Spain in this indication?
Yeah, in Spain, for example, is still not formally reimbursed, and it depends. I mean, in each institution has taken its way to lead with this issue. In my case, for example, you may ask for a kind of a special petition for individual patients, and patients are being approved to be treated following the LATITUDE schedule. I don't know, with the widening of a group of patients, if things will be as easy as have been until now. But
Matt, what about the US? What do you think about access for this particular indication of low-risk disease?
I don't think it'll be a barrier. It's already FDA approved, and payers don't really aren't too concerned about the extent of disease.
Okay, okay, so very important. I think there was also a second abstract from STAMPEDE,
There was. Actually, just to stick with the first one just for a bit longer, we showed data at ESMO last year, which we haven't published yet, showing really quite marked synergy between radiotherapy and abiraterone in, for example, N0, N plus disease. And the interesting thing about that was that the tests for heterogeneity of effect was significant, suggesting that there was actually a bigger effect in that group than the metastatic patients when you gave radiotherapy as well. And the other thing about that was when you gave 2 years of ABI, because I've got patients in my clinic now who've been on abiraterone for 7 years, and I am concerned that we maybe don't need to give them for that long. Obviously, we don't know. But I think that's a question for the future. So the second abstract, we were obviously delighted. So we incorporated radiotherapy for newly diagnosed metastatic disease in the trial around about the same time we set the abiraterone arm up slightly afterwards. And because of all the stuff around docetaxel and volume, we reclassified we got the scans in, reclassified them. And secondly, the HORAD trial had suggested there might have been a benefit difference between high and low volume disease. We prospectively reclassified the scans and did all of this before we did the analysis. And what we saw was a very clear effect on failure-free survival across the whole population. But that was bigger in the low volume patients, a lot bigger. And no survival effects in high volume patients, but remember up to 4 metastases, the hazard ratio is 0.68, which is somewhere in between the abiraterone and the docetaxel benefit in the same population. So highly significant effect from actually a very simple treatment. And around 20% of these patients had docetaxel as part of their standard of care, and the hazard ratio was the same with or without docetaxel. So it does suggest that it would be reasonable, and that is the conclusion we have come to for our next randomization, that for this group, the standard of care, or a standard of care, will be ADT, docetaxel, and radiotherapy to the prostate.
Okay. Is that practice changing outside the UK or inside the UK?
I think that is, because coming back to your previous point about the approvals and the regulations, it's easier to get radiotherapy through than it is a new drug. We don't have the same restrictions, so what we need to do is rewrite our radiotherapy protocols locally, and we can do it. So it's something that we could start doing effectively next week. Is it the right thing for everybody? Same thing, conversations we were having before. There may be a group of people who don't need it. Radiotherapy does have side effects. Interestingly, in the trial, the incidence of UTIs and bladder symptoms wasn't greatly bigger in the radiotherapy group, and in fact there's a suggestion that it might prevent further trouble down the line in terms of urinary tract symptoms. But it does have some short-term effect, and it has an impact, of course, on the patient travelling up to the hospital for treatments, particularly if they're elderly. The fact that there was a very pragmatic allowance to use different radiotherapy schedules is one of the strengths, I think, of the trial, and that we could say, actually, in this group of patients, we'll just give the 36-in-6 dose. It's minimal impact. Most people can manage that. We're getting some significant benefit from that at no great cost.
All right.
So I think it's a nice practical one.
Right. So will we change practices in Spain and in the US?
Well, I think so, but at least tumor boards will be much more interesting. I mean,
Okay.
because there have always been this kind of very selected patients that you would like to, or you would even decide to give radiation therapy to the primary. But as before, with the first STAMPEDE abstract that we discussed, now you have the data, and very solid data. And something that was really highlighted in the presentation, I think it's important, it's not a subgroup analysis, like something bad. I mean, it was a pre-specified subgroup analysis, very solid, very robust data. So I think that now you have data to do what you have always wanted to do in some selected patients.
Okay. Matt, do you buy it?
Much the same, yeah, I do buy it. And we've done so in selective patients without good evidence, so now we'll do it in more patients, with greater confidence that we're providing net benefit to our patients.
Okay, so we're making progresses. Great. So let's continue moving on with natural history of the disease. Metastatic CRPC, really harder to treat patients. I guess we've heard some good news and bad news. ERA-223, combination of abiraterone and radium. Can you comment on the results, please?
Sure. So the study was designed to look at this combination of concurrent Abi and radium-223 with the primary endpoint of SSE-free survival. And the study was unblinded early after the more dense deaths and fractures were observed in the radium group, and then the study proceeded to its final pre-specified analysis, and the final results of the primary analysis, there's no significant difference in SSE-free survival, and in a preliminary OS analysis, no difference in overall survival. But there is harm. There were more fractures in patients who received radium-223, and then by a variety of analysis, it looks like most of those fractures are osteoporotic. So certainly, based on these findings, we would not recommend the combination of Abi with concurrent radium as first-line treatment for mCRPC. The other, regulatory information has changed in various countries based on these results. And the other interesting observation of the trial was that only about 40% of the patients came into the study on bone health agents, which begs the question of why so low, but that's kind of what's been seen across trials. Patients on both bone health agents had fewer fractures in both groups, although it didn't spare the patients entirely from the radium, the adverse effects of radium on bone.
So, sorry, Álvaro, will you change the way you're treating patients with radium? Will you use it, in later stages, post-Abi-Orenza? Will you systematically use either denosumab or zolinic acid together with radium?
Yeah, I think throughout the UK, radium's very much been a third-line treatment. Once we've exhausted other options, people have tended to do it sequentially rather than in combination. So
Okay.
I don't think it will have a big impact on our practice. But I think the point about the bone health is really important. Ever since the early days of STAMPEDE, when zoledronic acid didn't seem to show much benefit, we haven't
In
really...
the hormone-sensitive setting.
Exactly, yeah. We haven't really focused very much on bone agents in prostate cancer, whether it's denosumab or bisphosphonates. And there's been a smattering in the trials, but it's been very variable as to the percentages of people who've been on these agents. Yet it's a big problem for the...
Sure. Nick, something?
Yes, I think in STAMPEDE, obviously, we were focusing on cancer-related bone events, and there was very clearly not benefit in STAMPEDE from doing that. But I think what Matt's highlighted is that this was not cancer-related bone effects that were increased. It was the
Mostly osteoporotic fractures.
It was the damage to the normal bone that was the problem, and I think it's answered a very important question, because at the St Gallen consensus meeting we had a lot of debate about if you're on an abiraterone and you're responding, do you need to give anything else? And the answer is very clearly yes, you absolutely do.
Okay.
I think now.
Well
from your
said.
data,
Yeah, I agree.
Yeah.
Yeah, and the other part was sort of like the endpoint for the trial was intended to be a cancer-related event, which is this SSE.
Yeah.
But when you dig deep into that, you find out that some of these events, which are thought to be pathologic fractures, really are osteoporotic fractures. And I'm as sure as I can be, this is not unique to this trial. It's probably the case in a lot of other studies as well.
Sure. I guess we've heard also good news at this Congress in men with metastatic CRPC, PSMA targeting and PSMA assessment, PARP inhibitors, Triton 2 trial, for example. Any comment about all this data?
Well, I think that mainly for PARP inhibitors, there was a promise that this could be the first targeted therapy for prostate cancer, right? Because the incidence of the previous studies, about 11 to 15%, somewhere in the middle of germline DNA repair defects, involving mainly BRCA1 and 2, but also ATM and other related genes. So the data, Triton 2, as we were commenting before, revealed that if you have a good biomarker, the drug will work, but if you don't, the drug won't work at all. So maybe we have been misled by the hype of ovarian, breast cancer, etc., seeing those high responses and very durable responses. And the first data by Triton 2, although are appealing, above 40% of responses, also show you that maybe all the DNA repair defects are not the same. So we have been putting together BRCA1, 2, ATM, PALB2, CHEK2, whatever. And for example, there was no responses in the ATM cohort patients, so we may have to rethink which patients are included in these trials, and which patients could be potential candidates for the drug. I think that, of course, is the step ahead. I mean, we are trying to better select our patients based on biomarker, but maybe the biomarkers is not still perfect. I mean, it gives you a hint of what you should do, but BRCA2 may be the most important one. BRCA1 is very uncommon in prostate cancer, and ATM and other related genes may be less active and maybe less important.
Right. Any comment on PARP inhibition or PSMA?
I suppose anything in general with these sort of biological aspects of the tumour is how much we're changing the biology of prostate cancer by more and more upfront treatment. And we may see that the resistant clones are coming through earlier on, perhaps, now that we're using all our best agents up front. So it could be that the pathway of the disease is changing, and these agents might be more appropriate after failure of lots of upfront therapy.
Yeah, in fact, the rate of somatic mutations in BRCA and related genes grow. I mean, each line you give, the higher the percentage of mutations you find in the tumor, so it makes sense.
Okay. PSMA or PSMA targeting? Any comment?
It's a very interesting concept, isn't it? You can image the disease with a PSMA-based radionuclides, and if you just hook a warhead up instead of an imaging isotope, obviously you're targeting radiation. So it's a very appealing concept. And the data, there was one of the posters was data from this. I guess that the response rate looks high, but the durability of the response is rather like the PARP inhibitors. It doesn't look quite so impressive. And of course, these are heavily pre-treated patients. Sure. But actually, there was a very nice poster from Michael Morris looking at characterising patients with positive PSMA PET scans, the PSMA expression on the circulating tumour cells, and a lot of the CTCs did not have PSMA expression. So there is, of course, a mixed population in the cells. So I guess it depends how mixed, because if they're mixed enough, you'll get bystander effects. If they're not mixed enough, you won't. So I think, it's in phase 3 trials, so it looks exciting, but we'll see.
Absolutely, it was fine. Now, let's go back to localized disease. One big question is whether we should use a more sustained systemic treatment for these men. We've been using combination of ADT, 3 years, 2 years, a year and a half, whatever, together with radiation for many of these men who are not treated locally with radiation. And at the moment, I think it's fair to say that we're wondering whether we should integrate to this kind of combination the new agents, including abiraterone, docetaxel, and enzalutamide, maybe others. So we could report at this meeting all our own data from France from the JEDUC 12 trial, with a 12-year median follow-up now, and that was comparing radiation ADT versus the same plus 4 cycles of docetaxel-based. We had already reported the RFS data, and relapse-free survival was significantly improved. We already knew it, with about a 30% reduction in risk. For the first time, we were able to report clinical relapse-free survival, counting only local relapses, metastasis, or death. And what we saw was a statistically significantly 25% reduction in the risk. And I guess the STAMPEDE data will be also analyzed soon, and hopefully in the US, the RTOG data will be also reanalyzed with longer follow-up. So based on this data, I would be very curious to know, what do you think? Should we already integrate docetaxel-based chemotherapy for these men, or at least some of these men with high-risk localized disease, or is that too early, we need more? Matt, what do you think?
Well, this, we're talking about sort of benefits and harms, and given the long natural history of this disease, this is even high-risk disease, it's really a situation that demands careful consideration of the patient in front of you. So I think of it, the individual patient with high-risk diseases, what is his cancer-specific mortality? And in other words, what are his competing risks? So I look very differently at a 55-year-old guy with T3 Gleason 9 and then, a 75-year-old guy.
So what about your first scenario? Would you?
Would I ever? That kind of question.
or future?
Yeah. So, we certainly have that conversation. And, as the younger they get and the risk ramps up, the probability of them actually dying of their cancer increases. And so that is a patient who I would have considered such treatment, and certainly will consider more of it in the future based on your evidence presented at this meeting. And there's going to be a lot of other evidence to follow. Sure. I mean, it's behind what they're going to lack is the long-term follow-up of GETUG-12. But there are certainly other studies looking at AR inhibitors, et cetera, looking in a similar patient population.
Right. Nick.
So we presented data at GU ASCO beginning of the year, which we published a couple of weeks ago, looking at the quality of life as measured by EQ5D in these patients, because they relapse later, because there's an effect on failure-free survival. It means if you've given radiotherapy and a fixed duration of hormone therapy, you've got a considerable period of extension to your time off treatment, which turns out to be very good for your quality of life. And the other thing that we showed that as previously we reported, very consistent in all of those docetaxel and abiraterone trials, is you reduce SSEs by about 40%.
So does this mean that you are already treating patients in your routine practice with high-risk localized disease with docetaxel-based chemo?
Yes.
Yes.
So,
Okay.
So I was going to say, of men going into STAMPEDE with M0, around a third are having docetaxel as part of their stated standard of care. So it's clearly widely done in the UK.
Yeah, I've only done it within the trial, so the number of patients. Same.
What about in Spain?
I don't think it's standard, of course, but I mean we're almost there. Adjuvant chemo in a lot of types of tumors, high-risk tumors, has reached a sustainable benefit, not a huge benefit, but it's a remarkable benefit in extending survival. So I think that in prostate we're almost there.
Cool. So we have good news. So with that, I would like to thank the four of you. This was really fun and very interesting discussion. And I would like to thank eCancer for having us tonight, wrapping up the data from ESMO 2018. Thank you very much. Bye-bye.